Hello, my name is Geert Meyfroidt. I'm a professor of intensive care medicine in Leuven, in Belgium. And it's my pleasure to talk to you today about something else than COVID, which has taken up all our time now, namely about monitoring of cerebrovascular autoregulation at the bedside. These are my financial disclosures, none related to this talk. I will start with the introduction. So our brain is our most important organ and is dependent on a high blood supply to meet its energetic needs. And actually an organ that only has about 1 or 2% of our body weight consumes 20% of our cardiac output. This is a very old paper, an Italian paper by Angelo Mosso, who describes the case of an Italian man named Luigi, who had a cranial defect because he was hit on the head by a brick. But that allowed the researchers to assess the volume of the brain as well as a measure actually of cerebral blood flow. And what they saw is that when they talked to Luigi about the first time he met his wife and the impression she made on him, they could actually see an increase in blood volume, in volume of the brain, so an increase in blood volume. And there was a steal effect from the foot, so in the body there was less blood supply. So we know that activity regulates cerebral blood flow. Now, when it comes to cerebrovascular autoregulation, because I've been asked to tell you how to monitor this, it's very important that we know what we're all talking about. And what we will talk about right here is actually about the physiological mechanism that allows us to maintain a constant global cerebral blood flow in response to external stimuli, and in particular in response to modifications in blood pressure. We assessed this, so in 2019, September, we had a consensus conference about this in Leuven in Belgium, which will be published soon. And there was a lot of discussion on what would be the best clinical definition. Actually, this was the best definition we could come up with. And so this slide is something you all know from medical school, where we've been learned that there is a plateau of cerebrovascular autoregulation, where the vessels are active and where higher blood pressures are compensated by vasoconstrictions up to a certain point, which we call the upper level of autoregulation, where there is passive vasodilation because the smooth muscle of the vessels is no longer able to sustain the high blood pressure. And then on the other side, the lower level of autoregulation, or the lower limit of autoregulation, where there is passive collapse of the blood vessels because there's not enough blood pressure. And we thank this to this man, this graph, who is Niels Lassen, who published a paper in 1959, where he actually described the plateau of autoregulation. Now, you might think that these numbers here present individual patients. Well, they do not. They actually present several studies. And this is one of the papers that could be published in the 1950s, but that probably would not get published anymore right now, where you can group such a diverse set of studies and present them as one data set. Cerebrovascular autoregulation, or the regulation of cerebral blood flow, has many determinants, and Joe Donnelly, who used to be a PhD, who has a PhD now at the University of Cambridge, summarizes very nicely in this review article in Critical Care in 2016, where he summarized all the determinants of cerebral blood flow and also the factors that could disturb it, such as a stroke, vasospasm, or tissue-related issues such as edema. And actually, the main site of cerebrovascular autoregulation is at the pile arteries. And in an experimental settings, you can look at pile arteries. So this is what Sam Klein, one of the PhD students of Bart de Preetre and myself, has been doing in the lab, where we had a piglet model, where we created a cranial window where we could look at pile arteries and where we could measure red blood cell flux as well as the diameter of the vessels. And this way we could actually measure the component of flow and the component of vasoconstriction separately. And Sam was able to nicely recreate the Lassen curve in his patient, in his pigs, where you can clearly see the lower and the upper level of autoregulation. But actually, if you look well, you can see a third phase here, where the vessels are at maximal vasoconstriction, but where you can still see an increase in blood flow. And this is something that we will publish soon, the details about this study. We have a paper under submission where you can actually clearly see that there's actually 3 breakpoints in cerebrovascular autoregulation. Now, when is cerebrovascular autoregulation impaired? Well, we know that it's often impaired in traumatic brain injury, and that the degree of impairment is larger in older patients, also in some types of injury, for instance, diffuse axonal injury, with also large midline shifts, tends to dysregulate the autoregulation. Thick subarachnoid hemorrhage do this, deep lesions do this, edema does this, sustained elevations in ICP do this as well. When it comes to therapy, it's less clear. We looked at it in our own data set in retrospect, actually found no impact of propofol or norepinephrine, 2 of our very frequently used drugs to treat these patients on cerebrovascular autoregulation, and also found no impact of anemia on how autoregulation works in these patients. Now, if you have a TBI, it's good to have active autoregulation. And this graph is from the paper we wrote together with Fabian Guisa, where we divided the ICP, insults of elevated intracranial hypertension according to intensity, so level of ICP, but also the duration of the insult. And this is actually, this blue line is the line on the right side of this line. Insults were associated with worse outcome. On the left side, they were in general associated with good outcome. And this is where the curve goes to if autoregulation is intact. So if your autoregulation works, you can actually sustain higher ICPs for a longer time. Whereas if your autoregulation doesn't work, like the red graph here, it's the other way around. You're not able to sustain high ICPs any longer. So it is important to autoregulate. Now, how can we assess cerebrovascular autoregulation? You can assess this in a dynamic way or in a static way. Now, the dynamic way of assessing autoregulation is something that is more reserved for experimental setting, because it involves inducing a rapid step change in cerebral perfusion pressure, which is obviously not desirable in patients. The static rate of autoregulation is something you can do in patients. It means that you don't take into account the latency with which the change in cerebral vessel tone occurs. And for instance, in this paper from the Cambridge group as well, they induced an increase in blood pressure, and then they measured what happened to the intracranial pressure, they measured what happened with the transcranial Doppler signal, and they went to imaging where you could actually also see the geographical changes in brain perfusion induced by the change in blood pressure. So this is something you can assess, but of course it's not a monitor, because you cannot take your patients into a perfusion CT scan or a PET CT scan all the time. So ideally you would be able to do this continuously without having to expose the patient to other ranges of CPP, where you can determine the breakpoints, and a monitor that preferably learns fast, that is non-invasive, and that is cheap. Because if you want to, if you impose extreme CPPs to your patient, obviously this can severely damage the brain. So you could use spontaneous fluctuations in the blood pressure and a measure of cerebral blood flow to study the phenomenon of autoregulation. So what you use is you use a surrogate marker of CBF, and you use spontaneous fluctuations in CPP. And then if CBF varies together with the blood pressure, this patient is pressure passive or not autoregulating, whereas when there's an inverse relationship, the patient is autoregulating. And there are several mathematical techniques to do that with. Now, of course, if you use continuous measurements, there's noise in that signal, so you know that signal to noise ratio is low. So you have to take into account that your measurement will be less precise. And so that's why you have to do these multiple sequential estimates to account for that. Now, you can use several measures of cerebral blood flow. So you can do TCD, and you can calculate an index that uses a Pearson correlation coefficient that is called the MX, that actually calculates the correlation between blood pressure and TCD signal in a continuous way. You can use near signal, you can use brain tissue oxygen as a measure, you could use laser Doppler flow, or you could use the ICP, the intracranial pressure, provided that the patient is on the steep part of his PV curve. And so indeed, the MX is a Pearson correlation coefficient every 4 minutes. You have to monitor MCA flow at least 20 minutes, but preferably longer. You measure MCA flow velocities, and you use the algorithm uses ICP and MAP averages over 6 seconds. And then you can see that this patient clearly has a pressure-passive relationship because there's a linear association between CBF and MAP, whereas there's an inverse relationship in this patient, which means that he's pressure active and autoregulated. Probably the best known or most used index is the PRX, and the PRX can be used in patients who are on the steep part of their pressure volume curve, where you know that increases in blood volume will be reflected by increases in ICP. And the PRX is also a Pearson correlation coefficient between average blood pressure and ICP for a time window of approximately 4 minutes. And it detects a change in autoregulation at the rate of between 2 seconds and 2 minutes. I will move a bit ahead because of time. Another way of doing it, if you don't want to monitor continuously, you don't have this system, is simply doing a small challenge of the blood pressure and then see what happens. For instance, you look at ICP, PbTO2, or cerebral blood flow at baseline. You raise the blood pressure 10 minutes while you're standing at the bedside, while you're knowing what you're doing by increasing the vasopressor dose, and then you reassess what happens to those signals. And so if autoregulation is intact, ICP should decrease or at least not change, whereas if ICP or cerebral blood flow increases, cerebral autoregulation is esteemed to be absent. What you can also do is reverse the ABP signal to look for the zone of optimal autoregulation. Now, this MAP challenge has been included in the latest CIBIC guidelines for TBI with all the precautions that are there. It has been criticized a bit, but still personally, I do believe it can be a reliable technique in experienced hands. So where are we now with autoregulation monitoring? Well, there's no consensus on a clinical definition of autoregulation. Dynamic rates of autoregulation monitoring is probably something you cannot do in clinical practice because it has it can potentially harm your patient. But you can assess the static rate of autoregulation by using imaging or doing a MAP or ABP challenge, or you can use the PRX or another mathematical index of autoregulation to have a good estimate. We don't know whether there's a clinical benefit of autoregulation-based management because you could steer the patient in the zone of optimal autoregulation by trying to aim for an optimal CPP. And actually, the trial that we are doing a prospective trial now, and we've finished including our patients. And you may expect the results of the Cogitate trial soon. We had some problem during the COVID pandemic because our study monitors could not visit all centers anymore, but that has been solved now. So we expect to start the data analysis soon. And with that, I would like to thank you. I hope I stayed within time. I hope you liked my lecture, and please do not hesitate to contact me should you have further questions. Thank you.